My name is Magdiel Habila. I am a second-year Master's in Public Health student in epidemiology at the University of Arizona College of Public Health. And the topic that I'll be presenting on today is the effect of hormone receptor status on breast cancer treatment in Dar es Salaam in Tanzania. So this will be the outline for the presentation today. First, I'll start off with a little bit of background information on breast cancer in general. And then we'll talk a little bit more about breast cancer in Tanzania specifically. So breast cancer is the leading cause of death in women globally. And as you can see by the numbers up on the screen, this disproportionately affects women in developing regions in the world. And the literature has said that there are a few reasons for why there's higher mortality in developing countries. Primarily, it's the late-stage diagnoses. So as you've heard from some of my colleagues that also did work in Tanzania this summer, most of the cases are diagnosed in late stages. But in addition to late-stage diagnosis, there is also lack of access to treatment. And then there's also lack of access to proper treatment if the patient is able to get treatment at all. So like I said, I conducted my study this summer in Dar es Salaam, Tanzania. And you can see it is all the way on the right here, next to the Indian Ocean. I spent the summer at Ocean Road Cancer Institute as well. It is, as you've heard, the primary cancer treatment center in Tanzania. And there are 52 referral hospitals that patients could potentially go to before they arrive at ORCI. So in 2016, hormone receptor status became required for treatment at ORCI. And so that means that a patient could not receive treatment unless their hormone receptor status was known at the time of their being referred to ORCI. And so following up on the work of two previous CEASE students, Ashley Burson and Taylor Sullivan, the goal of my study this summer was to determine whether the introduction of receptor status in any way changed the way breast cancer was treated in the time before breast cancer receptor status and the time after. So my methods this summer, I spent a lot of time looking through paper medical records. So if you could look on the flowchart all the way to the right, I started out with getting potential breast cancer cases out of the logbooks at ORCI. So I compiled a list of names and file numbers, and there were 782 of those. And so I would give a list of files to Suleiman, who was my research assistant this summer, without whom this project would not have been completed. And he would pull those files for me, and then I would read through the record to determine whether it was a breast cancer case. And there were 35 of those that were not breast cancer cases, so those were excluded. And of those that were left, 137 files were not found, and that could have been because they were misplaced or someone was using them at the time. And there were also 50 duplicate files. So I ended up including about 560 files in the 2016 and 2017 breast cancer cases at ORCI this summer. For every file that I looked at, I collected information on demographics, patient history, diagnostic tests, the treatment that they received, whether they had any recurrence or metastasis. And so this is just some of my preliminary results. You can see there was a pretty large age distribution in the patients who received breast cancer treatment between 2016 and 2017. The youngest patient was 21 years old, and the oldest was 102. As to whether that's actually how old they were, I can't speak to it, but that's what the birthday said. There were 547 women in the 2 years, and there were 12 men. Of the women, most women had 2 or 3 children, but some had as many as 11. There were 17% of women who reported any use of contraceptives in their history, but most women reported no history of contraceptive use. And for 57% of the women, this information was unknown. And that could be because it just wasn't included in the medical record, or the physician did not ask as they were collecting patient history. Some more results. About 26% of the patients who received treatment were insured with the National Health Insurance Fund. And so this is important because if their treatment was covered, they were more likely to complete all of the treatment and get all the different steps that are required in that process. But about 69% of the patients were uninsured, and so this could be a barrier to accessing the correct treatment protocols because the patient is entirely responsible for paying for their treatment if they're uninsured. As you can see on the table, or in the graph on the bottom left, most of the patients, both in the time before and the time after receptor status was introduced, were diagnosed in late stages, in stages 3 and 4. But there were quite a few unknown, unstaged patients. And this could be because the patient presented initially with very advanced cancer, and so it was not staged. But something that could also explain this is that a lot of patients go through one of the many referral hospitals, and the information that is collected at the initial referral hospital does not always follow the patient to ORCI. So for patients who made multiple stops along the way before getting to ORCI, they probably were not staged correctly at the very first place, and then would probably receive surgery or something like that. So there would be no information on stage at initial diagnosis. The table on the right shows the number and the percentage of the hormone receptor status for the patients who were tested, both positive and negative. However, I would like to note with this that about 46% of the patients either had unknown results or were untested. And another reason for this, again, is that if patients present with very advanced cancer, they're less likely to test receptor status. However, one of the obstacles that I saw in quite a few records was that patients were unable to pay for the immunohistochemistry test, and so they were not able to benefit from the tailored treatment that they would have received if they had been able to afford this test. And so this is why insurance status is relevant in this particular case. So now just a little bit of information about breast cancer treatment protocols at ORCI in the US and in Europe. The two on the right are, you can see, is the protocol for ORCI. The one in the middle is for the United States according to the American Cancer Society, and the one on the far right is the treatment protocol as provided by the European Society for Medical Oncology. It's kind of a lot to take in, but in general, these three treatment protocols are very similar. The biggest difference, well, they're similar in the fact that they have 4 stages. Surgery is typically the first treatment, and then there's chemotherapy, radiotherapy, and then some sort of hormone therapy after that if it is relevant for the patient. The biggest difference in these 3 protocols is that the United States and in Europe depend on early stage diagnosis. So the protocol for the US and the protocol for Europe are assuming that patients are able to be diagnosed in stages 1 and 2. However, as we discussed in the previous slide, most of the cases in Tanzania are diagnosed in stage 3 and 4. And so the issue that presents is that a lot of the treatments that patients have to receive would be considered more drastic by US and European standards because they're so late stage. So one of the most common surgery interventions for patients who receive chemotherapy at ORCI is a modified radical mastectomy, and that happens at the Muhimbili National Hospital because, as Dr. Chamberlain pointed out earlier, there is no surgery at ORCI. So patients are referred to Muhimbili for surgery if they have not already received it, and then are sent to ORCI for chemo and radiotherapy and hormone therapy. There are 3 common types of hormone therapy, tamoxifen and arimidex for the women who are ER positive, and then Herceptin for the women who are HER2 positive, and we'll talk about those a little bit more later. So this table that you can see shows the distribution of the most common treatments that are received by patients at ORCI. Most patients receive adjuvant chemotherapy, and a few receive both. And the two that I would like to point out specifically are the rates for neoadjuvant chemotherapy in the time before and after receptor status, and hormone therapy in the time before and after receptor status. And so you can see that in the time after receptor status, only about 12% of women were receiving neoadjuvant chemo compared to almost 23% in the time before. I'm not really sure why this is the case, but I think that it could be because the treatment protocols changed at ORCI, and so they were giving neoadjuvant chemo less often. But you can also see with hormone therapy treatment, in the time before hormone receptor status was required, almost 40% of women got some sort of hormone therapy, compared to 21% in the time after. And so you would expect to see this decrease because we're assuming that they'd be prescribing hormone therapy to women who needed it and not just to everyone who came in. But I am yet to determine whether or not all of the women who received hormone therapy in the time after receptor status was required actually needed it. So that's some of the analysis that I hope to do in the future. And this just shows the different types of hormone therapy that are prescribed at ORCI. Tamoxifen is typically given to women who are younger and premenopausal, Arimidex to older postmenopausal women, and Herceptin to women who are HER2 positive but are insured. And so if they're uninsured, they're not able to benefit from this medicine specifically. And that just has to do with how it's regulated with ORCI and the Tanzanian government. So for the future analysis that I would like to complete, like I said, I'd be interested in knowing whether or not the patients at ORCI are receiving the correct treatment according to the ORCI treatment protocols. Because according to the ORCI treatment protocols, every patient is supposed to receive radiotherapy. However, as we saw in this slide, only about 35% of them are. And so I'd be interested in figuring out whether that's consistent with all the patients and consistent over time as well. I'd also be interested in finding out some demographic information as well. So how far do people have to travel? How many stops do they make at treatment centers along the way before they get to ORCI? And that's important because of the transfer of information. I think Ugo mentioned earlier that information is not always shared across the different treatment centers, and so there could be information that's lost along the way. And the last one I'll talk about a little bit more in the next slide of tribal membership and cancer prevalence. So ideas for future students. I think it would be interesting to know what factors influence long-term follow-up of treatment for the patients who do make it to ORCI. And that's important for the women who are ER or HER2 positive, who have to be on tamoxifen or Arimidex or Herceptin for years at a time. Are they coming back to ORCI to receive those prescriptions? And if they're not, what are the barriers that they're facing to being able to complete their treatment? I'd also like to explore institutional barriers to standardized treatment protocols for all patients, because like I said, the adherence to the treatment guidelines for breast cancer on the surface does not seem to be very uniform. And so I'd like to explore what institutional barriers might be getting in the way of the standardized treatments. I'd also think it'd be interesting to explore the relationship between tribal identity and breast cancer prevalence. And this came up because as I was reviewing Ashley's data and Taylor's data and my data that I collected at the end of the summer, I found that members of a particular tribe are showing up about 10% of the sample for all the years that we have data for. And this particular tribe is about 2 million people, and so if they are having cancer as often in the actual population as they are in like the samples that we've been collecting over the past 5 years, that's potentially 200,000 people. So I'd be interested in knowing whether it's just that they're showing up more often, they're coming to treatment more often, or what's going on with that, because I don't have an answer to that question, but I think that it would be really interesting to have an answer because that's very specific, and I'd I wouldn't have expected that otherwise, I think. And finally, I think it would be interesting to see what barriers patients face to accessing immunohistochemistry as part of their treatment. So like I said, one of the things that came up in the records was that this test was very expensive and was unrealistic for patients to be able to receive the results for it. So what other barriers are patients facing in receiving this particular test, and what can be done to sort of break down those barriers and make accurate treatment more accessible to them. So my learning experience. I learned a lot about IRB this summer. I spent a lot of time waiting on IRB this summer, but we were able to receive it and everything, thankfully. I also learned about working in a cross-cultural context. As a lot of my other colleagues have mentioned, the concept of time is a little different, and so I think I went in with like this is what I'm going to do every day, and I'm going to get it done by this time, and whatnot, so on and so forth. But that didn't really happen because of difficulties with files, and Suleiman, my research assistant, was really good about explaining things to me about why I was having duplicate files and why files were not being found. And so that was a learning experience for me. I also learned about some systematic barriers to care. So a lot of the patients who come to ORCI for treatment are not from Dar es Salaam. A lot of them do come from places that are far away. The closest border, I guess, to Dar es Salaam is a 14-hour drive. And so if a woman comes from Arusha, for example, she has to drive 14 hours to get to Dar es Salaam to get treatment, and then come back repeatedly for follow-up. And so that's a huge barrier, having to travel and to pay for all of those costs. I also learned to apply the coursework that I've been learning in the first year of my master's degree to this very real-world setting. And that was a bit of a wake-up call for me, because it's not just like fake canned numbers anymore. Like, this is real information in real people's lives. And so that was important to learn. But I also learned a lot about the medical and insurance systems in Tanzania. Because like I said, and similar to the way it is in the US, if you can't afford treatment, you don't get it. And that is a burden for a lot of people. So the strengths of ORCI are that there are very knowledgeable and very dedicated staff who know their jobs and know their jobs well. Suleiman, for example, who was responsible for pulling all of my files this summer, had to explain to me multiple times how the file system works, because it's a very intricate and complex system. But like you have heard earlier, there's a new computerized system for tracking files and tracking patients, and so I think as that is integrated more into the ORCI system, that'll be a really huge strength for ORCI. One of the major weaknesses, I think, is the paper records, because of the handwriting in the records, because of the inconsistency of the data that is in the records, and because of the fact that they can get lost very easily. And so I think a few things that can be done to address that is to transition to the electronic medical record in a way that is smooth and practical. But I also think that one of the issues that I faced was collecting demographic information from paper records, because a lot of times that just would not be included, as the physician did not ask, or if they did ask, they didn't write it down. So there was a lot of information missing on like number of children, age at first birth, age at last birth, age at menarche, age at menopause, all of that information that's really relevant for breast cancer research. And so I think that if there was sort of a form that physicians could fill out so that they're prompted to ask these questions, then we'd have the data that would be very informative about the demographic information in the patient histories, and information that would go a long way, I think. And finally, the last point says give one file number to patients. And so I had, like I talked about earlier, there were 50 files that were duplicate files. And that was because a patient would come in one time without insurance, and so they'd get one file number, and they'd come in the second time with insurance and get a separate file number, and then they'd come in a third time either in January or like in July because in the middle of 2016 is when the electronic medical record was introduced. And so if they came in January, they would have a sequential number based on when they came in. And then if they came in July, they'll get a separate computerized number. And so as I was going through the logbooks, I would get multiple numbers thinking they were different people, only to pull the files and learn that they were the same person with 4 different file numbers. And so I think that as they continue to integrate and use the electronic medical record and figure out how that works well for them, that problem will take care of itself. But that was an issue that I ran into that was incredibly frustrating this summer. So my future career goals are to complete my MPH in May of 2019, and then I hope to begin a PhD in epidemiology. This summer really taught me that I am very passionate about breast cancer treatment in both the epidemiologic setting and also in the clinical setting. And so I would be interested in going to medical school to learn more about what that looks like in the physician-to-patient interaction type of world. And ultimately, I would like to work in breast cancer prevention, treatment, and control in Nigeria. That's something I'm really passionate about. So my acknowledgements, I would like to thank Dr. Solomon and the C Selection Committee for giving me this incredible opportunity. I learned a lot, and I loved being in Africa again. And that was something that I really enjoyed. I'd also really like to thank Dr. Jacobs. She is my advisor at the University of Arizona, and she played a huge role in helping me put this project together and giving me life advice about how to not quit on cancer research this summer. And I'd also like to thank the staff at ORCI, Suleiman, my research assistant, without whom none of this would be possible, and Dr. Masami, who was also my on-site advisor, who was very knowledgeable about explaining to me the processes of how things work at ORCI. And with that, does anyone have any questions?
I'm intrigued by a couple of things that you said. It was a very good presentation. My daughter is a physician who serves in a Hispanic serving clinic in Maryland that deals with both uninsured and insured patients. Mm-hmm. And the spoiler alert is the administration would rather deal with insured patients than uninsured patients. Here at ORCI, they're saying to be treated in our clinic, we now have declared that you must have your receptor status known, but uninsured patients can't have to pay for the test on their own and get those results and bring them in order to get in here. So either the intended or unintended consequence of that is that the number of uninsured patients that they treat at ORCI must be dropping. Mm-hmm. Again, intended or unintended. Right. I don't know whether you have any insights into that, but it seems paradoxical to say, to be treated here, you must have this information, and by the way, you have to pay for it. Unless you have insurance.
Unless you have insurance, right. I don't have any insight into that, but I think that's something to look into as I'm doing more analysis to see whether more insured patients received hormone receptor status than uninsured patients. That's information that I have, so I just have to sort of sort through it.
But more insured patients as a whole.
Mm-hmm. I think there were fewer insured patients in general. I think. Mm-hmm. Yeah. I think it was about 30% of the sample that I collected in 2016 and 2017 were insured patients. So I think there would be a few, like smaller subset of that that then received the hormone receptor status tests that they needed.
Two things. First of all, it's very, very good.
Thank you.
One thing that, though, a question I wasn't clear on, the slide that you had with all the treatment protocol in the United States, treatment protocol in Tanzania, treatment program in Europe, just a caution about that. That surgery, chemotherapy, radiation, hormonal therapy, that's for a specific stage and specific type of cancer. And I didn't follow it to the point where you said, that so many patients in Tanzania didn't get radiation. Mm-hmm. because it could be that they weren't in a stage that needed radiation, or they didn't have hormone receptors positive, and so they didn't need hormone therapy. If somebody presented in stage 4 breast cancer, they would only get chemotherapy for the most part, maybe radiation to painful areas and things like that. But that varies by stage. So I think that as you go back and look at it, take some caution.
Yeah, thank you.
The other thing that I was intrigued by was your observation that so many came from a certain tribe. And that's a great observation to go, there's something potentially there, to go figure out, that's a great observation.
Thank you.
And the third thing, and I don't know if this is available, going back to, the presentation that Dr. Cantor just made, about dose and stuff, is there any way to actually use this group to figure out if dose and response are related? Dose and survival are related. If you can get at that data, if the total dose of the drugs per meter squared, was this much or this much, did it make a difference in terms of survival? That may be a way at that.
Thank you.
I think that the latter one is going to be complicated by the late stage of presentation. I mean, we don't do very well with breast cancer at late stage in the U.S., no matter what dose we give. So if you have a late stage as being more prominent, then you're going to have poorer outcomes no matter what the dose is.
Yeah, I was thinking about this one where you had the percentage that were ER positive, PR positive. Yeah, right there. I heard, and I don't know the numbers in the United States well enough to answer that, but I've heard that quote triple negative, worse prognosis, the second line, is more common in both African and African American, and I don't know if 26%, 40%, and 43%. I would suggest that you look at what's the percentage and what's the percentage in other populations. Because in general, one of the reasons that people have thought that African and African American patients may have a worse prognosis is they have worse prognostic factors, these
Right.
triple negative, which are not so good.
And I was interested in that going into this study because as wanting to do breast cancer research in Nigeria, there is a high proportion of triple negative breast cancers in that country.
Yeah.
So that was something I was interested in. And so to the best of my knowledge, it was somewhere around 50% of women in Nigeria who had triple negative breast cancer. However, in Tanzania, it was closer to 15%. And I was reading something that said that depending on where you are in the continent depends on, I guess, like the spread of who is triple negative and who's not. But it is a smaller percentage, which was consistent with a lot of the other literature in the area.